So thank you, everyone, for the session today. We've invited Rich Hoffman to join us on the panel and perhaps make a couple of comments before we start taking questions from the audience. So, Rich?
Thank you. Just a couple comments. I do think that the shared decision-making and decision aids is a really necessary thing for this decision. Dr. Lefevre mentioned earlier that he actually thinks most cancer screening decisions are complex enough that we should be discussing, and so I certainly think this is the case. We know that primary care providers don't necessarily have the time, the experience, and they're not happening. And so kind of forcing us to use a decision aid to engage in shared decision-making, I think, is a good way to make sure both the patients and the providers understand what's going on. I think particularly for lung cancer screening, this is probably a higher stakes screening than we're used to. We're talking about potentially screening for 25 years. There's a radiation exposure, likelihood of false positive test. The invasive procedures, the treatments do have major complications. So I think it's important that people understand that. How we work it out best, whether it's something that providers can deal with or we should have them delegated to navigators, I think it's ongoing research questions. I do like the phases of education, and what was nice is actually with the VA has a separate decision aids after the results are back. When we talk about needing to make sure the patients are adherent with years of screening, with also recognizing the value of smoking cessation, I think that providing a number of different decision aids is going to be effective.
Great, thanks, Rich. So why don't we start on the right, and we'll just go back and forth like we've been doing earlier today?
Sure. Hello, I'm Lori Fenton-Ambrose from Lung Cancer Alliance, and appreciated all of the conversation. I had a question, Jane, about the VA. It's something we've obviously looked closely at as well. And I know when you present numbers, it's hard to understand them contextually. And so I'm curious as to whether or not the VA has looked at the costs of screening for other cancers in its system and how lung cancer screening might compare with that. And particularly given, as we know, that the military has upwards of a 30% higher incidence and mortality relative to the civilian population, which makes this an even greater public health imperative in some ways. So it's one thing to hear the cost, but it would be very interesting to know how that really compares relative to what the VA is spending for other cancer screenings. And I do know that DoD has moved forward rapidly and very effectively in launching and piloting and now deploying screening within its treatment facilities. I believe upwards of 5 now have lung cancer screening within their programs, beginning first with its flagship Walter Reed. And I don't know if you've had the opportunity, your team, to really engage with DoD, learn from them, share lessons learned as to how perhaps you can develop programs that might bring efficiencies given their lessons learned. Again, you may not know that, but it would be good to know whether or not DoD has been a partner or VA has reached out in that capacity. Thank you.
Sure. Those are great questions. To answer the first one, I don't know if a head-to-head comparison of the cost, say, for mammography screening for breast cancer compared to colon cancer screening, compared to lung cancer screening. I think it might be hard to compare those because, you know, for lung cancer screening, we're probably talking about cost to start a program versus established programs, so you'd have to kind of take that into account. But it's a good question and interesting to consider. I know in terms of colon cancer screening, there was definitely, and mammography as well, infrastructure that needed to be built up. So, you know, we could possibly learn from what happened with those, but with lung cancer screening and the kind of the long duration of follow-up as well as the false positives, those are kind of unique, I think, a little bit to lung cancer screening compared to the others, just in terms of, well, maybe not as much as, I guess what I'm trying to say is that I don't know if that all was considered like the way we're considering lung cancer screening, actually, because, you know, I think back to, say, when mammography is rolled out, maybe we learned lessons from that in terms of what was actually needed besides the mammogram machines. And so we're taking all of that into account now with lung cancer screening because of the lessons we learned there, maybe. So I guess I don't know of a comparison of cost, but I think VA's learned things along the way that we're considering now. I guess the point I'm trying to make. In terms of DoD collaboration, we have had some conversations here and there over the years with our colleagues there. I haven't kind of come together on implementation necessarily around lung cancer screening, although I know there's a lot of efforts in VA to collaborate with DoD on our medical record. There are some VA medical facilities that have joint agreements with DoD to share services, and that happens in California and some other places. And those are kind of set up deliberately to see what it would take to make that work. And so there is information sharing across those sites and those platforms, but it's not widespread as of yet, but I know that activity is going on.
Susan Schneider from the Oncology Nursing Society. We've heard a lot about effectiveness of lung cancer screening programs and heard a lot about the how and the where and the when and how often. I'd like to focus a little bit more on the who part of that. I've heard that we're concerned about the burden on primary care physicians and primary care providers, and I'm wondering about people's experiences with using nurses as part of the shared decision-making model. These are individuals who are excellent at patient education, patient communication. They're often used for informed consent for clinical trials, and so there's a whole group of individuals with that particular skill set, and I'm wondering how they were involved in your different projects. I think they were involved in some of the VA project, but I'd like to hear how you used nurses in your various programs. Thank you.
Everybody's looking down here. So I couldn't agree more. So there's one of the strategies for implementing a quality shared decision-making process is to use decision coaches, which is an approach that's been used in a number of different settings, including folks at University of Ottawa. And that's very much a nurse-driven model. So you have nurses who are trained in providing this information to folks and having conversations with them, and it's been incredibly effective, and there is a growing literature on it. I've not seen it yet make its way to lung cancer screening, but I think it's just because we're so new. But I think that's very likely to happen. We certainly had multidisciplinary teams represented on our development teams in creating these tools. And for the AHRQ toolkit, it's certainly something that we think would be appropriate for nurses, nurse practitioners to implement. But I think it's too new yet to know if how that's going to look, in the lung cancer screening context. But it makes perfect sense, and I think there's a lot of momentum already in place for it.
Did they use them at the VA? Did you use nurses as your coordinators?
There were some coordinators who were nurses. It's an interesting thing within VA. If you have worked there or know of that, we have specific scopes of practice for nurses, and it depends on the scope. Some of that's determined locally at the facility, some of it is national. Nurse practitioners, advanced practice nurses are able to, if it's within the scope, which it usually is if they practice, say, primary care or a specialty, able to obtain that informed consent. With other nurses, such as RNs, it may be variable. Licensed vocational nurses, maybe not, but it depends on the scope because they do have to achieve training and competencies. So,
thank you.
In Kentucky, we do use quite a few nurses that serve as the program coordinators, but we don't dictate any particular discipline because we're dealing with a lot of low resource areas, and so we really use the individual who has the passion, the drive, and the dedication to do it and to do it well, more so than focusing on any disciplinary background or.
Great, thank you.
Hi, I'm Michael McInnes. I'm a radiologist from the University of Toronto. I have a question about lung rats. The lung rats table is very slick, and it's very easy to use for experienced users. But if you go onto the website, on the Lung Cancer Resources website at the ASAR, it's a paragraph and one or two tables. And I think a lot of people are looking for explanatory notes or some rationale for some of the decisions that I know some of the rationale because I read some of the papers, but I find myself explaining it to colleagues and even to administrators who want to know about this kind of thing. What's the future for lung rats in the near future, version 2, or is there going to be an atlas or explanatory notes?
That is an excellent question. We are currently in the process of developing the Lung RADS Atlas, or Manual of Operations, that people will be able to go to get more of the contextual background and explanation, as well as an image-rich glossary of examples of cases that would fall into the different categories, either at baseline or over time. So that we very much know the need for that, and I've heard that message pretty loud and clear, so we're currently working on that. As opposed, the question about Lung RADS 2, it's a difficult one to know how fast to iterate. Lung RADS 1.0 came out in April of 2014. Lung cancer screening coverage came through CMS in the beginning of 2015, and we're just seeing practices in that early phase of implementing. And how fast to change, how quickly is always a question. We are committed to iterating and updating. We do have a Lung RADS call scheduled in a couple weeks, actually. And we might make some minor changes, but not too fast, too quickly, until we have reasonable evidence on which to make those changes. So you might see a 1.1 or a 1.2 before we get to a full 2.0, recognizing we're in this early implementation and lots of practices are just coming online, and to change too quickly might be too much and create more heterogeneity than it actually helps.
Just one suggestion would be to increase the font size in Lung RADS 2.0.
He's young.
Point well noted. There are also many individuals have been developing little apps that are available for download to help people with lung RADS, and many of the vendors with their software tools have built in ways to plug in the nodules in the software that readers use to spit out the right lung RADS category. So there are some tools out there.
I increased the font and put it on 2 sides of legal paper for the older radiologists in my group.
And that's where I put these on when I'm reading.
Thank you.
Yes.
Bob Smith, American Cancer Society. Ella, earlier Bill Black showed results of a study showing rather worrisome patterns of interpretation, in particular scan range and detection of cancers. And I think we see this problem in breast. We see this among gastroenterologists. It's not radiologists only, that the lack of proficiency testing, I oftentimes don't want to express it that way. More importantly, lack of regular feedback on initial interpretations and what else happens. It was a real barrier to not only knowing how good you are, but getting better and learning from your mistakes. And that has implications both for benefits and harms. So I'm wondering what potential you may see for pathways to assessing, measuring, and improving interpretive skills, and could it be part of the designated center criteria? Those are 2 questions, actually.
There's a lot in there. I think we don't yet know what the right approach is to these big image data sets. If I listen, for example, to Bill, he starts, or in that study that was quoted from Dr. Rubin, they start with the thin 1 millimeter-ish image of which there's 400 of them to go through. And then they go to what we call the MIPS, which are these thicker slabs on which the nodules kind of pop out like buds on a tree. Other people use the opposite strategy. They use the MIPS first, find the nodule, and then they go to the thins when they characterize. That way you scroll for positive things first, and then you characterize them on the thins. Those 2 different strategies may work differently. So I think we still have a lot to learn about what is the best strategy. And then we also have a lot to learn about the implications and use of computer-aided diagnosis in practice. We saw early on, before NLST started, there was a lot of activity in the vendor space about developing computer-assisted tools. And then when NLST started, a lot of that really softened and quieted down. Now that there's coverage for lung cancer screening, we're seeing lots of activity in the software vendor space to develop those tools and bring them to market and improve them as quickly as possible, which should give radiologists reader tools to help level that playing field in some of the same way that it's done for breast cancer screening, where computer-aided diagnosis is a regularly accepted part of practice. So I do think we have a lot to learn about what is the right strategy to start. When you're looking at the images, what do you do first? What do you do second? How does that impact that variability? And then what's going to be the role of computer-aided diagnostic tools as well? So learning a lot from what's happened in the breast imaging world, and then applying that to lung cancer screening, I think will help us a lot.
Okay.
Jamie Ostroff from Sloan Kettering, and I too want to thank you all for a really enlightening panel, particularly reminding us that decision making is a process, not an event. And I think several of the talks today really remind us to think about what our how do we define quality decisions, and that we go beyond. I think somebody made a comment this morning about a sort of a simple yes/no metric for around engagement. So I want to thank you for that. And I have two questions. One is, a lot today is talking about lessons learned from mammography and colorectal cancer screening. And again, many of us in the room are wondering what lessons can we learn about decision making around cancer screening to avoid the disparities that we've seen in uptake of screening in mammography. And I guess for those of you that are developing decision aids, or other observations, what can you tell us either about the importance of targeting the decision aid or the educational messages? To what extent are you involving families in discussions about screening? But really my question is, what are we bringing forward to make sure that we can make different mistakes, but not the same mistakes that we made with colorectal cancer screening and breast cancer?
Thanks a lot for that, Jamie. So one of the things that we're doing is actually that I didn't highlight very much when I was talking is that we're trying to reach out to the desired target, difficult to reach population in designing the tools. So the participants in our mixed methods study and our usability tests are not from Lexington, Kentucky, which does as best as we can for metropolitan, but we're actually in Hazard, Kentucky and Moorhead, Kentucky, and really approaching those individuals and in those community settings that are from a little bit more difficult to reach populations, and making sure that that's where our efforts are. And indeed, the Dr. Burns population in South Florida and Miami is also an underserved population. So we're trying to get away from the usual suspects, the usual highly educated individuals, and developing our tools with them, but rather getting into the harder to reach populations. That's the one thing that we've tried to do with the design of our tool.
Thanks.
Hi, it's Joanna Stoms from the Pennsylvania Department of Health, and I have a bit of a clinical question for the physicians. There's always this discussion that the patient must be asymptomatic when they are getting a screening, low-dose screening. So what constitutes asymptomatic when you have a patient with a 30-pack-year history of smoking, and they probably present with some symptoms of COPD, such as shortness of breath or persistent cough that could also mimic signs of lung cancer? So I just wanted to know what your thoughts were on that.
Actually, that was actually a question that came up with the first draft of CMS, because it said asymptomatic for lung disease. You're right, those patients all have a cough. My interpretation, I think the wording is signs of lung cancer. So coughing up blood, unexplained weight loss, fevers, night sweats, things like that. But you're right, I mean, the shortness of breath, the cough, the wheezing, that's what makes them eligible for lung cancer screening.
I'll just say at VA, we talked about that because we don't know the answer of how many patients may have had some kind of symptom, but were still referred for low-dose CT. We don't know, but we think it's probably some percentage. I think you can tell the providers what the criteria are, but they may or may not remember exactly to apply them consistently. So we always thought that would be a great question to ask and answer within VA.
And I'd also ask furthermore that even if you have clear criteria of how much cough, how much sputum production, how much change in cough, how much change over time, within an individual who's coming forward for screening, they don't necessarily know that their cough is more of a harbinger of cancer than their neighbor's cough who also smokes. Right. So what's normal for them just feels normal sometimes when it's really evidence of cancer. So it can be very difficult. And I think that may be part of why we're seeing a higher rate of positive screens than we expected in this kind of first wave. It's an enriched sample. There are a lot of people out there who may be at risk for cancer who have these indolent symptoms that are different than just the usual smoker's cough or smoker's sputum production that may be coming out for screening, sort of the tip of the iceberg. But it's a very good question to try and how do you actually codify what's normal for a smoker?
Thank you.
I think we're almost out of time, so I'm going to ask one last question before we're done, and this is for Ella. So as a designer of decision support tools, I thought it was very interesting your comments about how ACR is now using lung rads, and CMS is requiring the use of ACR-accredited lung cancer screening facilities. So does that mean that all of our decision support tools are now dated, and we need to update the evidence, in particular around positives and false positives, when we communicate this information to patients? And I hope you say no.
Yes. So I think because of those links, right? Okay. CMS requires a registry. ACR is the only registry. We require lung rads. We require registry sites to be all patient screened, not just Medicare. It basically makes lung rads the de facto standard, and based on those thresholds of positivity, negativity, downstream diagnostic tests, yes, okay. I think it does.